So anyway, if we look at some of the guidelines as to what the experts recommend for travel, this is from a recent publication for long-distance travelers at increased risk of VTE. I'll mention the other thing I'll mention. If you take all the patients who have developed a blood clot in their leg or the lungs after an airplane flight, say, and you ask them about other conditions, you'll find that most of them, not all, but most of them have something else going on. They either have an underlying cancer that they're being treated for, or they may not even know yet, but comes out in the next few months, or they're obese, or they have heart failure, or they have some other medical condition that adds to the risk. So it's not, and many of them also have things like factor V Leiden or prothrombin gene mutation or whatever. So it's really the individuals that are most at risk are the people who have several risk factors that come together in addition to immobility, sitting on the plane for a long time. When you add them all up, then those are the people that get blood clots, because we know there are millions of people that sit on a plane and get off and have no problem. So you have to have a number of risk factors that add up together. And then they suggest that using either these compression stockings or, if you can read this here, I don't have to read it for you, but I think the bottom line is that these experts for long-distance travelers, we suggest against the use of aspirin or anticoagulants to prevent VTE. Now, I will say, I'm not going to talk about it, but given the new types of anticoagulants that we have now, which you're all probably familiar with, where you take a pill and you're anticoagulated like that, so I personally have thought about this and maybe changing my thoughts in some patients that, because in up to the present time, if you wanted to give a prophylactic dose of an anticoagulant, it was either warfarin was not good because it takes days to get somebody anticoagulated, if they're not on an anticoagulant, or the other way is to give a shot of a low molecular weight heparin, Lovenox, and that's cumbersome and it involves some problems. But now with new pills, it's easy, but still, you don't want lots and lots of people taking an anticoagulant, a blood thinner, when they don't really need it, and you know that some of these people may end up having a bleeding problem, even with one pill. So you don't like to necessarily do that. I'll just mention that flying is not the only, I don't know if anybody in this audience plays Mahjong, but in fact, this was a story in the New York Times 2 years ago with a player who they blamed sitting for long hours playing Mahjong. So if you play Mahjong or canasta or whatever it is, a bridge or things like that, and you sit for hours on end, be careful. Move your legs. In fact, the best advice is, and what I always tell my own patients if they're going to fly and they have let's say they have an increased risk, I tell them to not only just get up and walk around, but be a little fidgety in the seat and flex your ankles and compress your calf veins and move around a little bit in the seat to keep the blood flowing. And that may be all that's necessary. Now, just a word about diagnosis. I'm not going to, maybe some of the other speakers will talk about this, just to show you, though, that the major way we diagnose DVT today is with an ultrasound. Many of you have had this already. And basically what we're doing is, if this is looking at the cross-section of a vein, is to put a ultrasound transducer that sends a sound wave down, and it bounces back, and you can get both an image and a reading from that. And if you press down, you can compress that vein. And the basic signal that we're looking for is not necessarily a picture of the clot, which you can get with an ultrasound machine, but it's really non-compressibility. You can't squeeze that vein, which is kind of the basic sign of a blood clot in the lower leg. If we just, a slide or two about therapy, and that is, I look at therapy for DVT or PE. Again, we treat these very much the same as a very acute phase, meaning early phase, a sort of subacute or more chronic, and then the long-term chronic phase. And generally today, up until recently, and again, we have to get, I'm not talking about the new drugs, the next speaker may, but the standard treatment has been a rapidly acting anticoagulant like heparin or low molecular weight heparin or some of these that you give an injection and you immediately get anticoagulated within an hour or so or less. And you are on that for a good, usually a good week. And then you start at the same time, you start warfarin or Coumadin, and it takes a good week, sometimes 10 days, sometimes 2-3 weeks to get your INR where you want it. And while you're trying to do that, you're on this rapidly acting anticoagulant. And when your INR is in therapeutic range, you stop that, and then you treat with warfarin. Now, certain patients, particularly those who have blood clot related to cancer, the recommendations today in general are to treat for 3 or 6 months with low molecular weight heparin and not warfarin. So that's something that some people may have had. And then there's this chronic phase, which goes on for God knows how long. It may go on for 6 months. It may go on for 12 or 24 or life, depending on how bad your DVT is, how many you've had, what the risk factors are, et cetera, et cetera. And that usually is with oral warfarin. Again, things are changing very rapidly now with the new oral anticoagulants. And so, you know, these are just some of the drugs that are used. The heparin is given, generally speaking, IV. Unless it's for prophylaxis, then it's given subcutaneously. Low molecular weight heparin is given subcutaneously. Warfarin is given orally. And this has been the only oral anticoagulant we've had since the beginning of time, up until the last few years. And now we have at least 3 new drugs on the market. Probably soon have a 4th one of these, and even more after that. I'm not going to go into detail here. You'll hear more of that from the next speaker. We have to worry about the long-term recurrence. In other words, there's a debate in everybody, and many of the patients I see in consultation are from other doctors of patients who have had a DVT or a PE. They've been on anticoagulants for 6 months, maybe 12 months, and the doctor says, can I stop them now? What's your assessment? What do you think? And there's no real good answer. You have to take a lot of factors and add them up, as well as the patient's, particularly with Coumadin, desire and to be on Coumadin, quality of life, and so forth, and say, what's the risk of a recurrent blood clot, and what's the risk of a bleed? Because there's always a downside, and we always have to balance that risk-benefit. And so, you know, these are just some factors that are present a risk for recurrence. Let me skip through that. This is a slide that looks at a number of patients. This is data from Mayo Clinic in Minnesota, and it looks like at the cumulative risk of recurrent VTE over about half a year here, which is around 5 to 7%. And here is a comparable graph looking at the risk of bleeding over a year or so in patients that were studied here. And you can see that if the risk of bleeding is about, so we all, anybody on an anticoagulant, you know very well that you're at risk of bleeding. And when I say bleeding, I don't mean bruising. Certainly that's a possibility, but serious bleeding, GI bleeding, bleeding in your head, and so forth, which could even be fatal. And if the risk of bleeding is more than the risk of recurrence, then clearly I'm going to stop the anticoagulant. And if the risk of the recurrence is more than the bleeding, then I'm tending to continue the anticoagulant. And if the risk is about even, then I toss a coin or so. But I have a discussion with a patient. And it really, it's not just the risk of bleeding. It's really a lot of other factors go into this equation in terms of how we manage patients.